Bienvenidos, bienvenidas. Estamos por empezar. Le damos la bienvenida a Craig Bryan, Pablo Gagliesi, Demián Rodante y María Poulisis. Les damos la bienvenida y empezamos.
Bueno, les pido un poco de disculpas por la tardanza en el inicio de nuestro seminario. Hemos tenido algunas dificultades con la actualización de Zoom y los canales de traducción simultánea. El doctor Craig Bryan es director de la División de Recuperación y Resiliencia. Es profesor en la Universidad de Ohio, en la Facultad de Medicina. Es director del programa de trauma y director del programa de prevención de suicidio. No quiero, su currículum es sumamente extenso, no me voy a detener en eso, pueden googlearlo. Él ha tenido la generosa disposición de tener una charla en el día de hoy, a pesar de que está atravesando un momento personal complicado. Y es el creador de la terapia cognitiva conductual para el tratamiento de el suicidio, que como se llama BCBT, que es una de las terapias en este momento más usadas en el tratamiento inmediato de personas con ideación suicida. Su currículum es sumamente extenso y estamos aquí porque lo hemos invitado a dar un seminario sobre este tratamiento muy pronto, en junio de este año, de 2 días, en donde nos va a entrenar en este modelo. Estoy acompañado de 2 colegas que trabajan o trabajamos o estamos interesados en el tema del suicidio, el doctor Demián Rodante y la doctora María Poulisis. Bueno, Craig, para empezar, lo que queríamos era que nos contaras brevemente de qué se trata el modelo de tratamiento que has propuesto. David, ¿pudiste traducir o no? ¿Podés traducirle aunque sea algo de lo que dije, como para que hagamos en este canal una traducción consecutiva, no simultánea? O sea que no lo tenemos resuelto al tema técnico. Are you listening to me, Craig, in this channel? Yes. Okay. I did a brief introduction. I did a brief introduction of your CV, and the idea is let me check something. La gente, o sea, yo acabo de hablar con él. Sigo sin entender cómo lo podemos resolver. No lo entiendo. Perdón. Él me está escuchando. ¿Vos me estás escuchando? No. Y si vos traducís consecutivo acá, ¿la gente nos está escuchando? Okay. So what we are doing is just solving the problem in some sort of way. The first question was, I did an introduction. I'm sorry for your loss. I know you're in a very private moment, and we are adding some stress to this. I know it's not helping, but the idea is they're translating us to Spanish in the other channel right now. So the first question was how you came up with the idea of the treatment and some basic ideas of this treatment. No one in this room knows you a lot, so it's not like Demián and María that we've been reading your work and since a while. So I would like you to introduce the treatment for all.
Sure. So thanks so much for inviting me to join, and thank you for your compassion as well. Yeah, it's been a very hectic week for us. You know, to answer the question, where did we come up with the idea of BCBT, or how did we kind of construct the idea? You really have to sort of go back, I think, multiple decades to look at the history of suicide prevention treatments and interventions as a whole, which I would argue started with dialectical behavior therapy, or DBT, developed by Marshall Linehan. That treatment was found to be very effective. It reduced suicide attempts, primarily by teaching people how to better regulate their emotions, how to respond to stress and upsetness in a more effective way. One of the challenges with DBT, at least in the United States, is that it's very time intensive. It's oftentimes 6 to 12 months long, takes individual therapy and group skills training, contact with patients in between therapy sessions. And so in the U.S. healthcare system, that's just a really hard way of delivering meaningful, high-quality healthcare services. And so in the 1990s, David Rudd started to develop briefer forms of suicide prevention treatments that would fit a little bit more within how our healthcare system is structured, which is typically one-on-one, face-to-face therapy, and that's time-limited in nature, typically only several months long. And so many of the ideas from DBT can be seen in BCBT. I would say there's one major change, though. In BCBT, we focus, I think, a lot more explicitly on cognitive reappraisal, on the belief system that somebody has. And the term that we use is the suicidal belief system. These are very negative, internalized core schemas. Things like, I'm worthless, I'm no good, I'll never amount to anything, I deserve to be punished. And a key part of BCBT is focusing on these negative thought processes and teaching patients how to challenge them and how to change their thought processes so that they're more balanced and less negative. And the research that we've been doing now in the past several years suggests that that addition to BCBT may actually be a really, really important piece of the therapy that contributes to its reduction in suicidal behavior.
Obviously, all of us, we work in DBT, and in our region, it's very difficult to support the idea that every suicidal client should be in treatment for at least 6 months, do group therapy, and it's very expensive and in various forms, time and money. So it's very difficult to offer DBT for everyone. And on the other hand, we see a lot of clients, they might not need all this treatment, by the way. You have a very, one of the things, you did several research on this treatment that is based on this appraisal. Maria and Demián can also put some questions in here. So if you're open to talk about that. How do you think the last research that you've been doing are showing that maybe we can scan a lot of clients that might not need longer treatments and give them this kind of treatment, and we will be fine with that? So one of the questions that had Maria, we've been talking about your treatment yesterday, Maria, I don't know if you remember that, was what happens if we have a reactivation of suicidal thoughts in the future? You've been doing some research on how many clients that have been doing this treatment, if they are do or not have the reactivation of the symptoms.
Yeah, that's right. So there's a couple, I think, important ideas that you're referencing there. One of which is the possibility of shorter, more targeted treatments. That was very consistent with how we were initially developing the therapy. And it's something that I've thought about a lot, that, you know, maybe different people need different types of therapies, or they need different intensities of therapies. It's something we're currently researching, where do some people need specialized longer term care, whereas others might need or can benefit from more targeted, shorter term treatment. And I suspect that's probably what we will ultimately find, right? That there is no one treatment approach, no one treatment duration that is right for everybody, but rather there's going to be more of a matching type of paradigm. And so, of course, to do that effectively, we'll have to start figuring out, well, who gets which therapy. And so we're working right now on precision medicine as well as patient profiling processes to start figuring that out. And so I think then with the second issue that you raised in terms of recurrence of suicidal behavior, you know, after someone is done with therapy or maybe at some point in the future. Yeah, that is something that we're looking at as well. We've seen in our studies of BCBT that somewhere between 1 in 4 to maybe 1 in 3 patients, depending on the study, will still attempt suicide, even though they're receiving what we believe to be is the most effective treatment available. And the question becomes, well, why? And what do we do about that? And some of the way that we're thinking about this now is that the first possibility is that the thing that prevents suicide, whatever that mechanism is, maybe we're just not hitting it hard enough. And so maybe we need a bigger dose. This is where maybe longer term therapy plays a role. But the second option we've been considering is that maybe there are multiple mechanisms. Maybe suicide is facilitated by a handful of pathways or a handful of processes, and maybe BCBT only hits one of those multiple pathways. And if so, then what that means is we either need to modify and adapt the therapy to hit a broader spectrum of mechanisms, or perhaps there's a different treatment altogether that hits one of those other targets that perhaps we need to be looking at. Whichever option ultimately ends up being true, it kind of gets back to this notion, this importance of being able to do a better job of profiling patients from the start, so that we perhaps can move away from right now. I kind of feel like a lot of us often just sort of do whatever the best that we can, and if that doesn't work, we just try something else, sort of a trial and error approach, and maybe we can be a lot more deliberate from the outset to help people much more rapidly.
Okay, I don't know. Thank you for answering those questions. I think one of the problems we're facing right now is that you wrote about this in your last book, but we don't know the processes that work. We know that the treatment works, but we don't know each part how that works. You shared the experience of hand washing in medicine. We didn't know that there was bacteria down there on that time, but so we might look down into the process and know which are the parts that work best and all that. So one of the things I was wondering is that we do have treatment that works. We don't know how that works, how those treatment works in some of them, but there's a problem is that we push people to ask for help. We are saying you have to ask for help, and it's very difficult to get help. I mean, it's not that easy. So what do you think about the spread of the word of the treatments that work in suicide? I know that it's one of your goals in life, so I wanted to know, what do you feel and think about that?
Yeah, it's a point that I do make a lot, where I kind of feel like the way that we often approach suicide prevention is to say, help is available, and so we'll screen people, we'll identify people who are suicidal, and then we'll say, well, now go get help, go get treatment. But the vast majority of treatments that are available, are not particularly effective, at least for reducing suicide risk. And the concern that I have, and that many others have, is that perhaps we might contribute to a sense of like hopelessness or demoralization amongst people, because if they're not receiving an effective treatment package right out the gate, they might lose faith within the system as a whole and say, actually, I don't think anybody can help me. And that's certainly a dynamic we've seen in a lot of our patients who come to our clinic for BCDT. Is they've been in a lot of treatment for a very long time. And they almost, they have the skepticism when they come in, where they say, like, I've already done everything. What could you possibly have to offer me? And it's interesting to then hear many of them as they go through BCBT to say things like, this is different. This is different from what I've done in the past. And I wish I would have received this a lot earlier in my life. The last thing that I'll say is kind of related to this sort of mystery right now of why do the treatments work, right? We know that BCBT, we know that DBT, we know crisis response planning prevents suicidal behaviors, but we have no idea why. And so this is something that we're working on right now at Ohio State. So I have collaborators who are using like fMRI methods to scan people before and after they're receiving treatment. We are now starting to kind of like breaking the treatment apart into its individual pieces, and we're randomly administering different parts of the treatment to different people to see, out of this 10 or 12 sessions, are there some sessions that matter more than others? And some of the early findings that we have suggest that, we've hypothesized for a long time that BCBT works by strengthening emotion regulation and helping people to be more cognitively flexible. And then some of our early research now suggests that maybe it's not emotion regulation per se, but it's emotional reactivity. And we're finding now with some of our imaging research that what we seem to be activating within the brain are regions that in essence allow people to not overreact when they're presented with stressful or upsetting stimuli or events in their life. And so it's a little bit of a spin, right? It's a little bit of a tweaking of what we originally thought, but based on what we're seeing, like, oh, that makes a lot of sense. And so we're hoping to bring that finding back into the treatment so we can do a better job of refining it. And we're getting to a point now where we are starting to figure out why and how does this treatment work.
Well, one of the things that most camps and jobs work, and your treatment, Marsh's work, Linneham's work, is, first of all, for us, is quite clear, is the focus on the problem. They are focusing on suicidal behavior. That wasn't the target 10, 20 years ago. Now everyone says that if someone comes with suicidal ideation, that's the focus of the treatment. It's just an hypothesis. This is not the place to talk about that. But at the end, it also works as exposure. Since you've been working in PTSD, I can imagine if you're struggling with the thoughts, but at the end you're not exposing yourself to the emotions related to the suicidal problem. So, but that's something. I would like to know if you can tell us how the training works and how are the results you're getting from now the clients are us. The clients are the therapist. If you think about training and fidelity or adherence, I know you've been doing some work on that, so I would like to here standardize the treatment, standardize the training.
Yeah, we've the way that we've been approaching training now for a few years is we typically have a 2-day workshop. We have demonstration videos. We also very strongly believe that role play is very important for clinicians, so that they can actually start to practice some of the concepts. Because there's a lot of times where, when we're talking about treatment from more of that didactic perspective, where people, sometimes clinicians say, oh, I'm already doing this, I already know how this works. And then we have them, role play, we have them practice with one another. And sometimes they'll kind of very quickly kind of trip over themselves and say, oh, wait a minute, this is a little bit different, a little more different than what I expected. And so we therefore say in the training process, this is the time to figure that out. You want to know that now when you're in a safe space, sort of with other clinicians, so that you can be ready to implement this more effectively when you are working with your patients. Some of the feedback we've received from clinicians is that oftentimes they're surprised by how focused the treatment is on the patient's experience. There's a very heavy emphasis on establishing and maintaining a therapeutic alliance. Motivational interviewing concepts are integrated into the treatment as well. And so it's very much a patient-centered approach. And I think sometimes there's a stereotype of cognitive behavioral therapies that it's very sort of mechanistic, it's very kind of dry, and there's not a whole lot of space for relationship. And so clinicians are pretty surprised often how attentive we are to those dynamics within the treatment process. And related to that, the last thing I'll say is that many clinicians say after they've gone through their training and they've started using ECDT, they kind of feel as though they're able to understand their patients much more deeply. They find that it's actually a little less anxiety-provoking to work with suicidal patients. And they feel, I've even heard clinicians say things like, I feel like I'm a human again. I feel like this is why I became a therapist, was to help people. And I feel like I'm able to now help my suicidal patients much more than I was before.
Cool. I think that at least I'm quite interested in doing the training, even though we've been reading your books and stuff, it's not the same. And I think that Maria and Demián will agree completely that role playing is a key part of the training. If we don't get the therapist rehearsal, doing some rehearsal, trying, talking about suicidal ideation, it's just an abstract learning in some sort of way. It's just like learning how to use a bike without just theoretically, without any practice. It's very difficult to learn some of these skills. If you could just think about your teachers or the framework, or I know you've been working with Rod for many years. Could you tell us a little bit about the background of this treatment?
Yeah, so as you said, I've been working with David Rudd for many years now. He was my training director when I was in graduate school. And gosh, I guess that's about 20 years ago now. And so I was able to learn therapy in general from David Rudd, particularly cognitive behavioral therapy. And, later on, once I was done with my degree, was in my early career stages, was when he started to receive some of the initial grant funding to further develop and test ECDT. And so he asked me to run the studies, and I said yes, and that was how things got going. And I really kind of felt like that experience of being able to run a research study, of course, was very transformative for my career. I saw myself as a clinician, and that really kind of actually redirected me down the research route. But some of what I learned through that process and from Rudd was, this importance of having an evidence-based outlook to really do what is supported by the science. It creates reliability for us as clinicians, and something that I learned from him was that if we just kind of make it up as we go, or do we really know what works? Do we really know how we're going to be able to help people? And is there any true sort of pathway that can be followed? And so I shifted earlier in my career as a result of that to start moving towards more protocol-driven, manualized therapies. Because prior to that, I had sort of a generalist training and kind of did the take different pieces from different therapies and put them all together. And what I found was that once I switched to the more manualized, protocol-driven approach, I was getting better results much faster. And that I think really stuck with me and has remained a big part of BCBT training. When I'm teaching clinicians, when I'm doing the therapy myself with patients, we really emphasize the importance of protocol, sticking to the principles of the therapy, and helping each individual patient being able to tailor the standardized approach to the unique needs of each individual that we're sitting in the room with, and that sort of balance of compassion and tailoring to the individual with making sure that we maintain this protocol seems to be a really important combination that I think is somewhat unique about BCBT.
Okay. It's quite interesting, the process, how you think. It's quite interesting. I mean, for the people that is in the room, there is an incredible book called Rethinking Suicide. It's a book that came out later. Was the treatment was first, and then this book, and you start in that book. You did an introduction writing about your own story related to suicidal behavior with this client, this soldier in the middle of it was Iraq, wasn't it? Or Afghanistan or Iraq?
Yes, Iraq, yeah.
So my interest with suicide was quite accidental. I think for Maria and Demián, that we've been working together since the beginning of times. Was that we were working at the hospital. We were getting a lot of suicidal clients at the door. We were doing this residency in psychiatry. We were 23 years old, and we didn't know what to do with these clients. We only had a residence of psychiatry in the second year to tell us what to do, that he learned or she learned from another residents of 25 years old. And that was our personal, I think it was our start, how we got interested in suicidal behavior. I wanted, if you think it's possible, if you could tell us how you got trapped into this passion in this amazing riddle, because it's a riddle at the end.
Yeah, so what I talked about in the book, and it is sort of my sort of story and how I became a suicide researcher and clinician. I had an interest in the topic, from the very beginning while I was in school. But it wasn't until I joined the military that interest was really solidified. And so I joined the military, the U.S. military, in around 2005. And shortly thereafter was when the U.S. military suicide rate started to increase pretty steadily. And so it became a pretty big concern in the U.S. military, and then suicide rates within the United States as a whole were starting to rise at about that same time. And so, there was a sort of timing effect where this interest that I had corresponded with just sort of what was happening within the world around me. And then in 2009, I deployed to Iraq and was working as a psychologist in a combat zone. And that was a very transformative experience for me. And so I was the only psychologist at this hospital, and so I was working on call in the emergency room. I also ran a clinic, and a lot of service members, if they would attempt suicide, they were brought to our hospital, and I would do an evaluation. Likewise, if someone died by suicide, almost always it was because they shot themselves with their firearm. They were also brought to our hospital, and we would provide care and keep their bodies physically functioning so that they could then be transported back to Germany and then the United States for organ transplants, to reunite with family, to say goodbyes, things like that. And so, there was this sort of other contact with suicide that was pretty unique for me. Up until that deployment, even though I worked with lots of people who were thinking about suicide, the actual act, the suicide attempt, the death, always happened somewhere else. It was at their home, in their car. And so for me in my clinic, I was never actually really exposed to the reality of suicide. And so while I was in Iraq, I saw dead bodies. I was standing at the foot of the beds of suicide decedents. And there was 1 week in particular that I talk about where, because of a sandstorm in Iraq, we could not evacuate low priority cases. And so we had this accumulation in that week of about three service members who had killed themselves. And so just kind of, seeing them side by side in our hospital, and in all cases it was a gunshot wound to the head, and really kind of seeing just how violent, how vicious and brutal suicide could be was a very significant experience for me in my life. I know that it's an experience that many mental health clinicians do not. They kind of confront directly. And so that was, for me, a moment where really I started questioning a lot of our assumptions about suicide, and started thinking to myself, we're definitely getting something wrong. And maybe we need to think about this and approach this in a new way, and to try something different out, because the status quo just really is not working. And that really kind of set the course thereafter for almost all the research that I've done since.
Okay, it's interesting how there's like this empathy thing that unites a lot of people that works in this field. Maria and Demián, you're open if you want to. We have 10 minutes more, but I would like to know if you want to make any questions. Maria?
Maria, you are mute.
Yes, of course. I'm sorry. I want to ask you something about the model. Some patients cannot replace their suicidal beliefs. We have this problem. And in the prevention phase, I'm very worried about the prevention phase. You talk about the cognitive rigidity, how patients, clients avoid connecting with the emotions that trigger the suicidal mode. Yes. And how can we address the difficulty in this phase so to allow the clients to use the tools their learning and on the whole treatment. Could you explain about this? How can we help the patients to replace their beliefs, please?
Yeah. So one of the ways that we approach that sort of shifting or changing of their suicidal beliefs is to really emphasize the unhelpfulness of what they're currently saying to themselves. And so, one of the perhaps classic ways of doing cognitive therapy is to ask someone, is this a rational thought or is this a realistic thought? And of course, one of the things that we learned very quickly when we were doing this is if we ask a suicidal patient, is this rational or reasonable to, be really negative towards yourself, to criticize you? They all said, yes, it absolutely is. This is true, right? And so some of the training that I received in, things like acceptance-based therapies, functional analysis, helped me to kind of think about maybe we need to change our lens just a little bit, instead of saying, is this rational or reasonable, but to ask, is this helpful? And we found that made the treatment process a lot easier, because now we weren't necessarily getting caught up in a discussion or argument about whether or not their beliefs were true or were reasonable. At that point, most patients would realize, well, no, it's definitely not helping me, because I feel ashamed, I feel embarrassed, I feel really terrible about myself. And so we could then move to a conversation of, well, I understand that you believe this to be true, and we're not going to argue that point. It's very clearly not working. And so let's maybe think about some alternative ways to view yourself, to view the world, that perhaps are much more workable, much more helpful, and are also true and reasonable. And that very subtle shift, just that changing of one word, right, from is it rational to is it helpful, seemed to make a really big difference with patients, because then it became much more about solving my problem, and helping me to achieve an outcome. And we found that patients also experienced it as much more validating. They felt that they were being listened to, that we weren't just kind of dismissing what they felt and what they thought, but that we could then help to, I think, sometimes lead them and guide them to a different perspective that oftentimes led to that reduction in those really aversive, uncomfortable emotions. And in some cases, we could get them to a place where they were starting to experience joy and happiness and other positive emotions again in their lives.
Well, that's true. When the clients get to notice the difference between content and function of the thoughts, it's a huge step in any treatment. Demián, do you want to do?
Yeah, thanks, Pablo. Hi, Craig. How are you? So, I have this topic is around my head a lot. I already discussed with Maria and with Pablo. There's two questions, but it's one topic. In the BCT, in a brief CBT program, what are the difference between the crisis response planning and a safety planning intervention? Because I'm pointing to the use within the crisis of reasons for living. As we know, the reasons for living can be protective factors, but at the same time, crisis triggers, because I don't know, I'm thinking about my children's or my job. So I understand that we can work that on during therapy, but when you have a crisis plan, last crisis response plan, and I think reasons for living, it's within the crisis response. How to manage this if the client in the next suicidal crisis of the client?
Yeah, so we've been asked that question a lot of sort of similarities and differences between crisis response planning and safety planning. And I think that's a understandable question. I mean, when we see crisis response plans sort of served as a precursor for safety planning, and there are a couple of differences that we've started to learn. One of which is from the contents perspective that you're noting here, which is there's an explicit inclusion of reasons for living in the crisis response plan that is not a part of safety planning. And so I'll circle back to that because I would argue the one content piece that's different. What we've learned in some of our newer research, we actually just published a study on this maybe about a month or two ago, where we directly compared crisis response planning to safety planning during the course of PTSD therapy. So we had suicidal patients with PTSD, and so we wanted to treat their PTSD safely, and so we compared the two planning approaches, and we found better results with crisis response planning. And we think, based on what we're starting to see now in a couple other studies with a similar results, is that a lot of it is related to process. And so one of the things that happens when you have safety planning, especially when people use the form, is that it becomes a fill in the box, fill in the blank activity, and it almost becomes like administrative, or sometimes I think it's also a very risk management oriented idea, where it's more about protecting the clinician and the agency as opposed to helping the patient or client. And so in the crisis response plan approach, we use index cards. And that was largely because I like to joke with clinicians sometimes about this. I'm like, I'm going to make you do some work, right? And so you don't have your cheat sheet. And I'm not going to give you little things to fill in. You are actually going to have to talk to your patient. You're going to have to listen to them, and you're going to have to engage them. You're going to have to join with them and collaborate and become a team to figure out not just fill in the answers, but why. What is it about those answers that work or don't work, and help that patient to customize and personalize the intervention for them so that it will help them to address their problems. And this is what we've heard from a lot of our patients who have received both interventions, is that in some cases, what is on the index card and what's on the safety plan is mostly the same stuff, right? It's similar warning signs, it's similar, coping strategies, similar people to call. But what patients say is that because of the nature of the dialogue that we had with the crisis response team, I get it. Now I see why something as simple as going for a walk would actually be helpful for me. Now I see why you want me to maybe call a family member or a friend when I'm upset. Before I just did it because that was the right answer, but I get it now. And so it increases their likelihood of actually using it. So now we're turning back to reasons for living, because that is one difference content-wise. So the original crisis response plan did not have reasons for living. We added it later based on some research that we did. And the idea behind this really came from the fact that many of us were working in emergency departments, crisis call centers, or even outpatient therapy. The modal number of sessions that someone attends in therapy is one. And so there's this sort of mindset of this might be the only opportunity we have to do something with this person. And so David Rudd and I started thinking about this, like we love the crisis response plan, but are we really moving the person's desire to die and the desire to live? And so if I only have 30 minutes or 1 hour, and this might be the only chance I get with this person, I want them to desire life. I want them to feel like living is worthwhile, and so we need to do something about that. And so we took the Reasons for Living task, which was a part of BCBT, and we combined it into crisis response planning. And the part of the feedback, the reason why we selected Reasons for Living was because that's what our patients were telling us was most helpful for them. They were coming to us years after therapy, and they had this little index card with all the reasons for living. And they said, this is the thing that I keep. This is the most important part of the therapy. So we listened to the patients, and we joined it, that activity with the crisis response plan. And what we found is that it actually does seem to result in faster reductions in suicidal ideation. And now this MRI study that I was telling you guys about before, that's exactly what we're seeing, is that there's something about this task that activates parts of the brain that helps a person to calm down, to not overreact to stressful situations. And so we believe that there's something about this discussion of why you want to live, or maybe what gets in the way of killing yourself, that is very important. And we have now, and we'll talk about this when we go through the training, we've got some strategies on what do you do when someone says, I don't have any reason for living, or yeah, I care about my kids, but I lost them in the divorce, or a loved one, a spouse who tragically died, so I don't have that anymore. And so we can actually help now walk patients through that process to say, even though maybe you don't have the same access to those reasons for living, or there's something about it that's different, it doesn't mean that there are no reasons for living. It's just that something is different now as compared to what it was before. And perhaps let's work together to figure out, in some cases, new reasons for living that maybe you didn't necessarily have before.
Well, I can wait for training to see how to work this point. Thank you.
Yeah.
Thank you.
What we learned is that we're not using any forms anyway. That we just grab a piece of paper, grab a pen, you start, the client follows you with a pen and the piece of paper in his hands. It's handcraft.
Yeah.
And we've learned that with your book. So we can't wait we're very anxious to do the training. We're so glad that you agreed to do this. I think this is the first time we're doing BCBT in Spanish. So everyone is invited. It's in June. You're going to get the invitations for that. We'll have simultaneous translation. Hopefully we solve the problem before that. Again, we are looking forward to translate your books. That's one of the things that some of the book will be translated for the training, so people can access to at least the BCBT book. But obviously, I suggest everyone to read Rethinking Suicide. Is one of the brightest book I've read in the last years. So you're more than just calling people to read that book. And we'll see each other in the near future. So in June, we'll be there. Okay.
Wonderful. I look forward to it.
Front row. And again, thank you. I know you've been through a harsh time right now, so our sympathy is with you, okay?
Thank you very much. I appreciate it.
Bye. Los invitamos a los demás. We'll invite everyone if they want to stay with us another 10 minutes with us, so we can change to the other channel, and we can keep on talking about the training and the rest. Thank you again, Craig. It was so nice.
Thank you, Craig. Thank you very much.
Thank you so
guys.
much. Have a good day, everyone.
Thank to you. Y ahora nos pasamos al canal en español.
Sí, entiendo que sí.
Ok. ¿Estamos en el canal en español ya? ¿Alguien nos puede contar si nos están escuchando en castellano?
Sí, perfecto, los estamos oyendo bien.
Ok. Hay 30 personas en la habitación. No teníamos mucho más tiempo con Craig. El doctor Craig Bryan nos comentó que está con un problema personal un poco complicado. Su suegra falleció en estos días, por eso fue el cambio del día de ayer. Pero como verán, está de hecho en un lugar, en un restaurante, porque no podía, han ido a un pueblo del interior de los Estados Unidos para eso. Pero estamos abiertos a que nos hagan preguntas sobre el entrenamiento, sobre el modelo de tratamiento. Tenemos unos 10 minutos extras. Tanto María Poulisis como Demián Rodante han leído, y yo también, el material, el modelo de tratamiento de él, y estamos abiertos a hacer a preguntas y respuestas. Pueden escribirlas en el chat o directamente abrir el micrófono y preguntarnos. De nuevo, muchísimas disculpas por el obstáculo. Probablemente Craig esté con una computadora que no esté con el Zoom actualizado. Estaba en una situación un poco complicada para presionarlo para que lo haga. Mil disculpas por eso retrasó también el comienzo. Pero estamos abiertos a que nos hagan preguntas. Eugenia, ¿o podés contarnos cuándo es el entrenamiento, por ejemplo? ¿Me están escuchando o no?
Sí.
Sí, te
Perdón.
estamos oyendo bien.
Ok.
Sí, un segundo. Ahí estoy. Dame un segundito.
Sí, entiendo que hay participantes que quieren escribir o hablar, pero no sé si están habilitados, Euge.
Ahí les estoy dando la habilitación. Igual todos somos anfitriones en caso que quieran hacer algo.
Mientras tanto, les voy contando. Bueno, antes que nada, mi nombre es Eugenia Olavide, trabajo en el equipo de BT Iberoamérica. El entrenamiento con Craig es el 6 y 7 de junio y con interpretación. Toda la información de qué se trata, de qué se va a conversar, cómo se va a trabajar, la pueden encontrar en nuestra web, dbtiberoamerica.com, así como el formulario para inscribirse. Entonces, los esperamos. Igualmente, cualquier consulta, cualquier duda, no dejen de escribirnos. Yo les dejo aquí en el chat el mail, que es coordinación@dbtiberoamerica.com. Ahí se los escribo.
Ok, ahí tienen toda la posibilidad de escribir o de preguntar. Entiendo.
Ahí va, listo.
Yo voy a decir algo, ya que estamos todos en silencio. Habíamos tenido una entrevista con Craig y me sorprendió lo amable que es, la verdad, y lo simple que es. La verdad que una persona que terminó a los 20 y poco de años en la guerra de Irak, enfrentando la situación de la tasa de suicidios más espectacular de la historia. Fue una epidemia de suicidios esa guerra. De hecho, se murieron más soldados americanos por suicidio que por las manos, digamos, por el enemigo, no sé cómo llamarlo. Así que creo que ha sido, y él contó un poquito esta experiencia de cómo lo marcó estar a los pies de la cama de alguien que se había disparado en la cabeza. Me conmovió un poco eso. Y bueno, si tienen ganas de hacernos preguntas o charlar un poquito del asunto, estamos abiertos a que abran el micrófono, ¿cómo se llama? La cámara o escriban en el chat alguna pregunta.
Hola, ¿qué tal? No sé si se me escucha.
Hola, Pía, tanto tiempo.
Bien.
Hola. Bueno, no, en mi caso, nada, estoy como muy intrigada. La verdad que me aparecen muchas ganas de conocer sobre este tratamiento. Me llama mucho la atención esto de las 12 sesiones de terapia, lo que hablábamos al principio, ¿no? Bueno, que hay una terapia que funciona se está viendo como más para una persona, otras para otra. ¿A qué nivel de estabilización de conductas se llega con estas 12 sesiones? Entiendo que quizás se trabaja específicamente lo del riesgo suicida, y bueno, queda quizás en etapa 1 de DBT, pero sin riesgo. Bueno, nada, la verdad me intriga mucho, me parece
No sé
que ya
si
me
te puedo
notó.
contestar, Pía, como muy brevemente. la mayoría de la gente con ideación suicida o conductas suicidas que llegan no van a necesitar todo el programa de DBT. Muchas veces una intervención más corta resuelve considerablemente el problema. La idea es targetear, es decir, volver un objetivo de tratamiento la conducta suicida en sí, y si el consultante requiere un tratamiento de trauma, un tratamiento de estabilización de bipolaridad, no sé, digo esto porque está también María en la mesa, eso lo seguirá después, pero lo interesante es que es económicamente, en términos de tiempo y financieros, mucho más probable que establecer un largo tratamiento de DBT que dura por ahí un año. Y los resultados son sorprendentes. Comparado con la terapia ofrecida normalmente, eh, 3/4 de los, o sea, anda 70% mejor que una intervención usual. No es poco. Eso quiere decir que si alguien llega a un servicio de emergencias con ideas de suicidio, un tratamiento que no hay tantos, hay 4 o 5, un tratamiento focalizado en el problema del suicidio puede ser una solución alternativa. No sé si María o Demián quieren agregar algo.
Yo quería comentar algo. El programa tiene 2 sesiones, ¿sí? Y algunas sesiones de refuerzo posteriores en la etapa de prevención de recaída. Pero lo que él hace foco, y hoy lo reforzó, y lo que también habla en su libro, Repensando el suicidio, es que él no hace foco en ningún tipo de trastorno mental. Y habla luego del programa, los pacientes siguen su tratamiento, por ejemplo, si tienen estrés postraumático, si tienen, eso es lo que estaba diciendo vos, Pablo, que acorta mucho la posibilidad de poder acceder a un tratamiento que dura menos de 3 meses. Los pacientes después continúan con el tratamiento que decidan según lo que evalúe su clínico, ¿no? Pero eso es algo novedoso, o sea, porque siempre estamos planteando tratamientos que duran un año mínimo, 2 a veces, ¿no es cierto? Así que son al principio 12 sesiones. Y la primera parte, que es la parte donde se basa más en la DBT, que es regulación emocional y habilidades, y plan de crisis, esa dura alrededor de 4 sesiones, si mal no recuerdo. Con lo cual es bastante rápido, lo que decías vos, Pablo.
Sí, y agregando a eso, hoy por hoy las intervenciones que reducen el riesgo de suicidio más efectivamente son las que hacen, como la BCBT, foco en suicidio y no en el resto de vulnerabilidades como puede ser el diagnóstico. Eh, lo que sí me parece importante es que como ninguna teoría y ninguna intervención encaja para todos los casos, eh, poder utilizar distintos programas o distintas intervenciones más largos o más cortos de acuerdo a la formulación del caso, acerca más a ayudar a las personas que implementar un mismo modelo todo el tiempo. Entonces, cuando estos programas se acercan a nuestras regiones, creo que es una oportunidad un poco única, porque muy probablemente DBT funciona para muchas cosas. De hecho, digamos, un poco trabajamos desde ese modelo, pero también hay otros consultantes que se podrían beneficiar igual o incluso más con otro tipo de programas. Entonces, creo que aumenta nuestras competencias formarnos en este tipo de intervenciones también.
Tenemos 2 preguntas en el chat. Bueno, un comentario de Cintia. Dice, hola, trabajo en Secretaría de Adicciones en Córdoba. En territorio nos encontramos con consultantes donde no cuentan o resulta difícil poder encontrar razones para vivir y quizás es muy difícil que estas personas vuelvan. Por esta razón me parece muy interesante poder conocer sobre este tratamiento. Cintia Maricel. Y después, un asistente anónimo. En los temas de formación continua para la intervención, ¿cómo nos podrían fortalecer sobre este tratamiento?
Bueno, una de las... muchas gracias, Cintia, me parece que es cierto. pero sería en territorio, como conozco muy bien el programa de Córdoba, de la provincia, o bien, me parece que es muy simple entrenar a alguien en 2 sesiones de entrenamiento, es decir, 2 días de entrenamiento, con el efecto social que eso podría tener, porque entrenarse en DBT requiere 120 horas mínimo de entrenamiento, es un entrenamiento caro, largo, y además hay que volver. Acá el entrenamiento es 2 días creo que si yo no me equivoco, son 2 días de 8 horas o 2 días de 6. Y el efecto es, podemos entrenar más gente, se puede entrenar más gente, con lo cual podemos tener más efectores en el territorio. A mí me parece que hay una discusión de cuán chica podemos hacer la intervención, cuán fácil, cuán accesible, qué tal si podemos reducirla a su expresión más simple para poderla enseñar y multiplicar su aprendizaje. Y justamente este es un modelo que es fácil de entrenar terapeutas. Los terapeutas en 2 sesiones de 6 horas o de 8 horas, no me acuerdo, consiguen capacidades para manejar estas entre 8 y 12 sesiones, con lo cual el efecto sanitario, si entrenamos gente, es monumental. O sea, cualquier otro tipo de entrenamiento de educación continua, siguiendo la segunda pregunta, requiere de muchísimas más horas. Esto es efectos rápidos, masivos, grandes, buena distribución, buen alcance, entrenamientos cortos, simples, con ideas no tan complejas, parsimoniosos. Pensé que eso es sumamente enriquecedor y bueno.
Pablo, gracias. Y quisiera agregar, para aclarar, el entrenamiento el 6 y 7 de junio es de 10 de la mañana a 6 de la tarde, hora de Buenos Aires. Es decir, en total son 8 horas cada día.
Ok. Me parece que está bueno que podamos, digamos, estos son los tratamientos. Yo siempre me pregunto, ¿no? Le pedimos a la gente con ideas de suicidio que pida ayuda, ¿no? Le decimos, lo más importante en la prevención del suicidio es el screening, es decir, preguntarle a la gente si tienen ideas de suicidio y ofrecer rápidamente un tratamiento. Y la pregunta es, ¿qué tipo de tratamiento es la que ofrecemos? ¿No? Es una pregunta compleja. No por tener más psicólogos o psiquiatras o psicólogas o asistentes sociales o enfermeros en el territorio, esto va a mejorar si no los tengo entrenados o si no están entrenados en un tratamiento basado en la evidencia, ¿no?
Pablo, yo te quería, pensaba, vos hablabas de nuestros años en los que estuvimos en el hospital italiano y de residentes ambos, y que en ese momento las crisis suicidas solo eran pensadas en términos de la guardia del hospital, como que se tenía que solucionar como una intervención de emergencia. Y ahora estamos pensando, y hace tiempo, y estamos viendo cómo los investigadores están haciendo foco en tratamientos que trabajan sobre la conducta suicida, independientemente del momento en que el paciente va a la guardia porque o ha hecho una crisis de autoagresión o una tentativa. Esto es el cambio de hace varios años que nosotros empezábamos, donde no se hablaba demasiado, sino se hacía más foco en el tema de la salud mental y no se hablaba en el tratamiento posterior al paciente que hizo una emergencia o una internación sobre la conducta suicida en sí. Y esto es algo que creo que ha cambiado un paradigma, por lo menos cuando nosotros empezamos a trabajar, ¿no? Hace mucho, no voy a decir cuánto.
Bueno, creo que estamos en la hora, son las 11:15. Les agradecemos enormemente la participación, que se hayan sumado. La verdad que es un lujo 40 minutos con Craig Bryan, siento como que, charlando con él, siento como que ya está. Es el premio del día de hoy, así me alegró el día poder conocerlo y charlar con él. Espero que ustedes también los haya entusiasmado. Muchísimas gracias, Demián y María, por arreglar horarios para poder estar de un día para el otro a las 10 de la mañana, un día viernes, no sé cómo hicimos para reprogramar esto. Así que muchísimas gracias por participar a todos. Espero que se entusiasmen con volverlo a escuchar o leer alguno de sus libros. Saludos y nos vemos pronto.
Muchas gracias a todos y todas por participar.
Chao,
Gracias,
chao.
Pablo. Gracias a
Chao.
todos.
Chao.